Hello people, in this video let us look at ectopic pregnancy. So a pregnancy which is in the wrong place is ectopic pregnancy. So here you can see that the pregnancy is here somewhere in the fallopian tube. So this is a tubal pregnancy. So let us see what ectopic pregnancy is. Ectopic pregnancy is a pregnancy or where the fertilized ovum is implanted or it develops outside of the normal endometrial cavity. Okay, it implants and develops outside of the normal endometrial cavity. They did not say outside of the uterus. Did you focus on that word? Did they say outside uterine cavity in the definition? No, they said outside of the normal endometrial cavity. That means in the uterus also it can grow in wrong place, and that can be called as an ectopic pregnancy. So look at the sites of ectopic pregnancy, guys. So where and all you think the ectopic pregnancy can occur? It can be extrauterine or intrauterine. Yes, it can be within the uterus also. So first you look at the extrauterine. Extrauterine, mainly you remember tubal, ovarian and abdominal. Okay, so tubal means what? In the fallopian tube. Okay, ovarian means in the ovary, and abdominal means in the abdomen. Okay, anyways, that is very rare. So now tubal means look at this, where and all maximum it can occur mostly in the ampulla, that is this bend, right? Ampulla. And then here isthmus. Where is isthmus? Here. Isthmus is this narrow region, right? There it can occur, and rupture also is mostly because if it is isthmus, it's so narrow and it will try to grow here, the pregnancy. So this can rupture. So where is it more common? Ampulla, then isthmus, then they are saying infundibulum, which is here, and then lastly they are saying it is interstitial, which is near this uterus, that ostia. Okay, so this is about tubal pregnancy. So did you understand tubal pregnancy, guys? So this is about tubal pregnancy. Now look at this interstitial. They have put a photo here. This is interstitial, they are saying. See, near the ostia, right? So that is interstitial. Okay, now let us go to ovarian. It is rare. Okay, then abdominal. In abdominal there are two things you should know: primary, secondary. What do you mean by primary? Primary means that it actually went there and implanted there. Okay, so that becomes a primary one, but that is very rare. Okay, it doesn't go all the way to your abdomen and implant. No, mostly it will. Secondary means what will happen, it would have implanted elsewhere, and then the body will try to abort it, right? It will try to get kicked out from that place where it implanted, and it can then go and reside in the abdomen. That becomes the secondary abdominal. Okay, so that is why I was trying to change this definition to implanted and develops outside, or implanted or develops outside. What do you say? Because sometimes it can get implanted, get thrown out, and then go and implant elsewhere also, right? Okay, fine. So so you have understood the sites of ectopic pregnancy, extrauterine. Now let us move on to in the uterus. So please focus here. In the uterus also it can be there, but still be called as a ectopic pregnancy. Why does that happen? People, now we are moving on to ectopic, but within the uterus. Okay, within the uterus, but ectopic. Look at this. So what if it goes and sits in the cervix? Okay, so it can sit in the cervix here. See, in the cervix it can sit, or probably there was a cesarean scar here in the lower segment of the uterus. It goes and sits there, right? Because some kind of an adhesion, some kind of a resistance in that place, it might go and attach there, right? Or angular. Angular means this ostia, right, where it's opening there. Okay, that can be angular. Cornual. What do you mean by cornual? So cornual means this photo here, you look. So a bicornuate uterus they have shown here, and this is cornual. So here what they are saying is there's no opening at all here. So they are guessing the sperm went via the open one, that is the sperm went like this all the way, and then it has come here and implanted from like this maybe. Okay, so that's what they are saying about cornuate. Now let's move on, guys, to the causes of ectopic pregnancy. Ready? What are we going to look at? Say causes of ectopic pregnancy. So mainly you will write salpingitis. That is tube. The salpingo means this tube, right? There is inflammation in the tube. So obviously inflammation and all is there. It will go and get attached to there. Okay. PID, pelvic inflammatory disease. So basically remember, some infection in this person. Some contraception has failed. So there was a contraception and that contraception has failed. So you can say there's a contraceptive method device inside and still there's an ectopic. So then you will have to think whether to keep this pregnancy or not. If it is in the right place, you can keep it. So you'll have to remove the IUCD in that case, right? Tubal ligation. So tubal ligation is really strange. So what they're trying to say is probably some ligation was done here for sterilization also. Is it something like that? But how will the sperm go on the other side and fertilize this ovum? Okay, some tubal surgeries they have done. ART procedures. ART procedures means like gamete intrafallopian transfer. Imagine they put a sperm here sperm here they put into the fallopian tube, right? Gamete enter fallopian transfer. So that time it could result in an ectopic, or probably they did an IVF. So in IVF it can go and implant in the wrong place, right? So that is another thing. So all these are normal causes of ectopic pregnancy. Did you understand, people? So let's look at more details here. Salpingitis, pelvic inflammatory diseases, means you'll have to mention about chlamydia. So there will be inflammation, loss of cilia. So because the cilia is required for the movement of this ovum from this embryo and all down this fallopian tube, right? For that you need cilia. What do you need? What do you need, people? Cilia, say. Focusing, right? You need cilia here. That cilia will be lost, okay? So that's why it cannot move and it will implant here itself. Lumen is narrow, so it's narrow. It is so narrow that even one small egg and sperm which has fertilized can't come out, is it? Okay. Adhesions, we told you if there are any tubal surgeries, inflammation could have resulted in adhesion, etc. And the tube is not straight, okay? The tube is not straight, so you're understanding, right? So all these things you will anyways write in the exam. Tube is so kinked, okay? Then coming to iatrogenic. Iatrogenic is IUCD. They have inserted an intrauterine contraceptive device, etc. Look at all these. Okay, these are the types of devices, like a Progestra cert and some progestin only pill, morning after post-coital pill they are talking about. Okay, so all these things can cause an ectopic pregnancy, they are saying. Did you get it, guys? Are you understanding what are we looking at? Is the causes of ectopic pregnancy. Okay, then tubal surgery, you did some reconstruction. She did not have a proper tube, you have done a reconstruction. Then when you did a reconstruction, that reconstruction can lead to a ectopic pregnancy. Intrapelvic adhesions and all you will write easily. ART, gift, IVF, ET, that is in vitro fertilization with embryo transfer. We already told you this, didn't we? Are you focusing? Yes. What are we looking at? Ectopic pregnancy causes in that iatrogenic. Others, so some previous ectopic if she had, then what will happen? Here again it will go and try to get stuck to the place because it knows something is there, some roughness, maybe it will go and stick there only. Then what else? Developmental defects of the tube. The tube itself development was not proper. Yeah, we told you, right? Kinked tube, very long tube these people have, or there's some diverticulum in this tube, or there is some accessory ostia, there are some extra openings in this tubes, is it? Okay, this is here because this is not what the doctor created, these are others. Okay, transperitoneal migration of the ovum. What they are saying is sometimes what happens, you will see that the ectopic is here, right? But the corpus luteum will be here. So that means to say the ovum came from here. So they think that sometimes the ovum, the fertilized embryo, etc., went all the way around the world and went and reached here and is growing. Okay, transperitoneal migration of the ovum. It's got a lot of energy, money, and stuff to do all this kind of migration, looks like. Okay, simply grow in that fallopian tube only. Why it is going all the way to the other fallopian tube? Anyways, so this is the etiology. So let's look at what the next slide is. So what is the factors that facilitate this nidation? We told you, right? Basically some adhesions, etc., etc. But what they are saying is there could be something to do with the ova. Don't always blame the uterus, fallopian tube and all. They are blaming the oocyte itself. See that oocyte, around it what will be there? Zona pellucida, right? So they are saying that this is the oocyte, around it that zona pellucida, it will degenerate fast. So what will happen when this prematurely it will degenerate the zona pellucida, this oocyte will have to implant. Where? Not here, here in the fallopian tube or anywhere. Okay, or if there is tubal endometriosis, so imagine the endometrial tissue is found in the tube. So anyways it will think, wow, this is the endometrium, and it will implant there. Looks like okay. Then increased decidual reaction. So residua is the endometrium, right, which is pregnant. So again some reaction of this endometrium could factors that can lead to the ovum awakening very much before and implanting. Did you understand, people? They are blaming the ovum or the oocyte. What do you call it? The embryo? Yeah, the zygote. Okay. So rising incidence of EP. What is EP? Ectopic pregnancy. Why the incidences are rising? Because there's an increased incidence of STIs. So sexually transmitted diseases are increasing, they are saying. Then obviously salpingitis. Then ART procedures are increasing. Nowadays we are ready to fix everything. No, assisted reproductive techniques. From the time that you can freeze your embryo, whenever in life you want, you can get pregnant. Okay. If you don't have embryo, we have embryo donor. If you don't have sperm, we have sperm donors. If you don't have uterus to bear it, we can get you a surrogate mother. What was I trying to draw here? Surrogacy. So basically there is nothing called as infertility nowadays. Okay. So everything can be fixed. Now look at this, increased tubal surgery. Yeah, increased tubal surgeries. You're working on the tubes more. Early detection of cases. So now whenever they come for they miss their period, they will come. That time they will check, they'll have ectopic probably. So you know that these people have ectopic. So the chances of catching it are more, because as soon as people get pregnant, they do come in, right? So that is why ectopic pregnancy chance seem to be increasing. Okay, so which factors increase ectopic pregnancy? Same thing they have written in different form. But can you prevent ectopic pregnancy? Yes, you can prevent ectopic pregnancy if you prevent infections. If you prevent, don't undergo too many reconstructive procedures. But who undergoes them? Unless they want only, they will undergo, no? Yeah. So abortions and all, if it's there too much before, IUD use. But IUD means they don't want to get pregnant, but still they got pregnant and now it becomes an ectopic. Okay, so you can't do much, guys. At least keep hygiene and prevent these infections. Okay, so prevention, we told you, you can prevent infections, that's all. Okay, now let us see this ectopic pregnancy. This embryo will go and implant in this tube. No, let us say it is implanting here. What exactly will happen? Do you know the levels? You have mucosa, submucosa and muscularis, and do you have muscularis? And then you have serosa. So you should know all these layers. Okay, that's why they're trying to tell you now how it is invading. Okay, so basically here you will see the implantation will occur between two muscular folds, mucosal folds. Okay, the muscles will get stretched, the blood vessels will get engorged. Yeah, you can say all this. Then there is intramuscular implantation. The blastocyst will burrow, so it will go inside and burrow. Obviously it wants to implant, that is the word, right? Then it will implant inside the muscle. Where? Inside the muscle. Then there is a pseudo capsule which is formed, which is consisting of fibrin, few muscle fibers, etc. Okay, then the blood vessels, look down here, the blood vessels are eroded by these villi. So whatever villi from this embryo, let us say here, this embryo villi are coming, what will this will erode all the blood vessels. So blood vessels and all will get eroded by this villi. The blood accumulates between the blastocyst and the serous coat. So this is blastocyst, and here you have the serous coat. Between that, what will you have? Blood. Okay, all this is the kind of pathology, you can say. Okay, now what will happen? Basically, this is not at all a favorable place for this ectopic to grow. So what do you think will happen? What do you think will happen? It will not get enough nutrition. It doesn't have place either. So this will not grow. Okay. Okay, let's go further. What will happen? We will see. The wall will become thin. Yes, this we know. Guys, are you focusing where it implanted eroded blood vessels? Okay, now what will happen to the wall? Wall will become thin. Blood will spill. There can be hemoperitoneum. Hemoperitoneum means there will be Cullen sign, Gray Turner sign, etc. Basically, there is blood in the peritoneal cavity. What they are saying is, if it ruptures, no, definitely there will be hemoperitoneum. Okay, even otherwise there can be hemoperitoneum. Okay, then the peritoneum, the stretching of the peritoneum, this will cause pain, etc. Then finally, what will happen? It will rupture. When it ruptures, what will be there? Hemoperitoneum, definitely. So they are saying blood in the pouch of Douglas, etc. Yes, are you focusing? What are we looking? We are looking at how this pathology, how pathogenesis is happening. Then basically this ectopic pregnancies, no, they don't produce as much HCG as a normal pregnancy. What am I saying? HCG in a ectopic pregnancy will be lesser than HCG in a normal pregnancy. I couldn't write the G. Okay, so you got it right. So in normal pregnancy, you will have more HCG. Where will you have more HCG? Come on, say it. In normal pregnancy, we'll have more HCG. Very good. Okay, then what will happen? See, they are saying there can be a tubal abortion. Okay, so it is coming out here. Tubal abortion, 3 diagrams they have shown here. So you can see here, tubal abortion beginning, complete abortion, and this is also complete abortion. Okay, so there can be complete abortion. Incomplete abortion also can be there. Then let us talk about rupture. Okay, so rupture, where and all it will happen, you know. Usually when it is there in this isthmus, Okay, isthmus and this narrow area, right, interstitial, here rupture will be more. Okay, let's not use a green, let's use a red. Okay, because it's rupturing and it's really dangerous. Okay, so this whenever it's in this narrow part, tubal rupture. So tubal rupture is where will you see isthmic and interstitial implantation. Okay, so isthmic and interstitial implantation you understood. Okay, now let us go to tubal perforation. Perforation, it can perforate the roof, it can perforate the floor. Okay, then continuation of pregnancy is rare. Very rarely it can continue the pregnancy and keep it going. Okay, did you understand, people? Did you understand pregnancy, what ectopic pregnancy, what will happen? Okay, there is one more thing here that they are trying to add here. What if it is a molar pregnancy? That means there's a wrong fertilization, right? So that also can go into an absorption or a abortion. Abortion is more common, looks like. Okay, it will go into abortion. Okay, so that's it, guys. So we have looked at the tubal pregnancy, how it will terminate. Okay, so we have looked. So basically the other things are that there will be less blood here, it will not survive, then there will be less HCG, there will be less progesterone, and then finally the endometrium will shed, there will be bleeding per vagina, there can also be rupture of tube. You know that there is rarely it can lead to secondary abdominal pregnancy. So the tube try to throw it out, right? But it will escape, rupture, whatever, perforate, and it will reach the abdomen and it will implant there and become secondary abdominal pregnancy, looks like. Okay, so that is one more option. It will find a new home, kind of a thing. Okay, now all this time that tube was suffering so much, what did the uterus do? Let's look at this, the changes in the uterus. So uterus was enjoying that somebody else is doing all the work, yeah, let's keep quiet, kind of a thing. So there is enlargement of uterus, increased vascularity, it's receiving all the blood and enjoying life. Okay, but it doesn't have chorionic villi. Okay, it contains evidence of chorionic villi. I didn't understand this. The decidua develops all characteristics except it contains it contains no chorionic villi, contains no evidence of chorionic villi. Did you understand this, guys? It's very easy to understand. Where are the villi? In the ectopic place, correct. No need to say tubal. Tubal is more common, but it can be anywhere that it is there. It is building its villi. Okay. When progesterone level falls, progesterone levels will fall because of fallen HCG. Then what will happen? The endometrium will shed. Obviously, there will be bleeding per vagina. So there can be a decidual cast. Okay, which you may think that it is spontaneous abortion, but that baby will still be there where in the ectopic place. Okay, it is the decidual cast which came out. Decidua cast. Okay, decidual cast. Okay. So now let's move on, guys. Are you ready? What is the next slide you think? What and all we have looked at so far till. We looked at what ectopic pregnancy is. We looked at the sites. We looked at the causes. Then we looked at the fate, pathology kind of a thing we looked at. Now what should we look at? Treatment? No, clinical features. How will the clinical features of these people be? They'll have abdominal pain, amenorrhea, vaginal bleeding. So basically, see, they would have missed their period just by 1 or 2 days. Let us say they may have abdominal pain, bleeding per vagina. Should always rule out pregnancy and ectopic. Okay, because very important, because she might have missed her period just by 2 days, and that is a very minor complaint, right? But still, it should rule out ectopic. Okay. Then she may have this hemoperitoneum. Hemoperitoneum means she will have these signs called as Cullen sign, Gray Turner sign. You have seen this in a many videos, right? Gray Turner sign, Cullen sign, hemoperitoneum. You've seen all this in pancreatitis also, right? So anyways, they can have syncope. They can have shock, guys, because of rupture or something. They can have shock. Here they are behind the uterus. They are showing you the pouch of Douglas where there can be blood. Okay. Now, what are they saying? The shock can be there. So that time, if shock is there, there will be cervical motion tenderness, fullness of pouch of Douglas, encysted blood. So this is called as some pelvic hematocele. Okay. Fine. Let's move on. So did you understand the clinical features, guys? So this hemoperitoneum, they are saying one more thing. Okay, because of this blood in the this peritoneum, right? There can be irritation of diaphragmatic. What is spelling of diaphragm? This can lead to shoulder tip pain. Okay, so this is something interesting, right? They can have shoulder tip pain. So if somebody tells you, a pregnant woman, I'm having shoulder tip pain. Is this the shoulder tip? Which do you think is this? So shoulder tip, this one? That could be ectopic pregnancy. Or hemoperitoneum, basically. Hemoperitoneum. Because of which the diaphragm is getting irritated. Okay. Now let's move on to the diagnosis. Okay, how will you, this patient has come in, now what and all you'll do for her? You'll first ask her to, if she's in shock, you have to directly treat the shock. Okay, no diagnosis and all that. Diagnosis means emergency care you'll have to do, but otherwise you can do transvaginal ultrasonography if you have time to do all this, right? And then all the HCG levels you will check, right? Then you will look for what and all blood examination, then laparoscopy, dilatation and curettage, serum progesterone you can check. That anybody will write, right? Blood examination, etc. So here mainly you focus on two things, okay? Beta HCG and transvaginal ultrasonography. That and all if you have time and if it is not an emergency situation, okay? Next, how will you treat? Guys, great, we have reached the treatment of ectopic pregnancy. Now focus here, you can do medical or surgical. Why say surgical or medical? You should say medical or surgical. Okay, now first of all, there is expectant management. Expectant management is everything is like resolving by itself. So you just wait and watch. So why will you wait and watch? Because you feel that the serum HCG levels are decreasing. The HCG levels are what? Decreasing. Their levels are falling. The gestation sac is small. The gestational sac is small. No fetal heartbeat. That means this is aborted. Is that the word we use? Okay, no fetal heartbeat. I'm making this green. I hope you don't get offended by it. Gestational sac is less than 4 centimeter. No evidence of bleeding or rupture. So it looks like she just came in and you are checking and there was, looks like an ectopic is regressing all by itself. Expectant management. Now let's move on to the next step, people. Okay guys, so now let us look at ectopic pregnancy treatment. Okay, you're looking at treatment of ectopic pregnancy. Now we are looking at what we have looked at so far. We looked at the expected management. That means when you see that it is regressing by itself, then you have looked at expectant management, just wait and watch kind of a thing. But now you feel that this is not regressing, then what will you do? So is it ruptured? No, it is not ruptured yet. Okay, so now what will you do if it has not ruptured yet? So the fallopian tube is fine, it has not ruptured, so you will also try to save the tube. So what you will do, if the patient is fine, they are hemodynamically stable, their serum HCG levels are less, not very high. Then if the tubal diameter also is like around less than 4 centimeter, they are saying, and there is no fetal cardiac activity, that's what they are saying, then you should, these people don't have any intra-abdominal hemorrhage, then you can do this kind of work. What you will do, you will go transvaginally or laparoscopic, looks like you will go like this, or laparoscopically you will go, and here you will put some drugs. What are those drugs? Like methotrexate and potassium chloride. Okay, all this you will give. Okay guys, so you will put what and all there, methotrexate and this is called a salpingocentesis or something. Wait, let's tell you the word. Here it is. So you will do what? You will do salpingocentesis. What and all you will put? Methotrexate, actinomycin, which is nothing but an antibiotic, potassium chloride, which is actually cardiotoxic, looks like for the heart, prostaglandin, hyperosmolar glucose, etc. Okay, so basically they are trying to put some cytotoxic methotrexate here, okay, in this place so that it will get absorbed. Then basically what will you do? If it is a large ectopic, then you can't do like this. Okay, you cannot go from here. They're giving systemic methotrexate. Okay, so what is the treatment for ectopic? Methotrexate. Remember, if it is not ruptured. Okay, then you will monitor the beta HCG levels until it becomes less. Okay, so this is what is the medical management. Then coming to surgical. Okay, surgical, what will you do? Surgical, they are talking about linear salpingostomy. So what you will do, if it is big and if the HCG is more of etc., they are doing this procedure called as linear salpingostomy. Stomy, S-T-O-M-Y. It's a mouth kind of opening they are leaving here. See, linearly they are making a cut here and they are opening and removing this gestational sac. Okay, and then they are leaving this without suture. They are opening a mouth here kind of a thing. Okay, this is linear salpingostomy. Stomy is mouth, right? Kind of a opening. So laparoscopic linear salpingostomy for unruptured tubal pregnancy. This is very interesting. No, why they are not putting sutures and all? They are telling that the textbook says that this will heal later by secondary intention, and if it is bleeding and all, then you do hemostasis. Okay, hemostasis you do by electrocautery or laser. Okay, So you should not let it bleed, but you can leave it open, and that will heal by secondary intention. That's what they're saying. So you understood linear salpingostomy. You should say the word stomy. Okay. If you put sutures and close it, no, that becomes a tomy. Okay. That they are not doing here. That is outdated now, and all they are not doing, or they are not done, right? Yeah. So now they are talking about stomy. Okay. Then they are resecting anastomosis. That means whatever portion was affected, that portion they are removing, that segment, right, without ectopic pregnancy, and the remaining parts they are anastomosing. So resection, anastomosis. There's one more thing called as milking the tube. So they are just bringing out the gestational sac, is it? And that's also not done. Fimbrial expression means what? If it is somewhere near this infundibulum, is it? So if it is fimbrial or distal ampullary, then they are just bringing it out digitally, is it? So fimbrial expression they are trying to do. Okay. So these are some strange things, but interesting, right? So that is the treatment for unruptured. If it is not ruptured, you can do all this. What if it has ruptured? What will you do? Ruptured tubal ectopic pregnancy. So basically the patient could be in shock, right? You have to do resuscitation simultaneously. You'll do a laparotomy, not resuscitation and then don't do laparotomy, or do laparotomy and then do resuscitation. Both you should do together. Okay. So other people will be working on her resuscitation, like by giving her IV fluids, colloids, etc. That is, there will be 2 IV lines. Okay, 2 IV lines they're opening, and they're giving fluids, and they're giving blood if required. Blood O negative, they'll keep it ready, but otherwise if you have exact match, you can give. Surgery they're doing here. See here, they're not talking about medical treatment. Did you understand? If it's ruptured, laparotomy. Tomy means what here they're doing here? They'll put suture here. Remember, they'll put suture here, and they can do salpingectomy also. Okay, all the surgery you saw that they can do. They're doing laparotomy. Okay, laparotomy means what? They will remove and they'll put suture. Okay, and then salpingectomy also. Total salpingectomy also they can do. Here they have just shown salpingectomy. You can see. Okay, so this is what they are talking about, ruptured. Okay. Let's look at this. There's something called here as the principle of laparotomy, quick in, quick out. Okay. That's what you will do. Quick in, quick out. Okay, now let's look at the scheme of management of tubal ectopic pregnancy. Don't get overwhelmed by that huge flowchart. We will break it up. Okay. So now let us look at this. Whenever somebody comes with all these symptoms, first of all, you will check the beta HCG levels, right? And then you will take a detailed history of that person, amenorrhea, abdominal pain, etc. You will check the beta HCG levels, ultrasound scan, etc. You will do transvaginal. You will prefer. Okay. Now, you should be ectopic minded. That's what they are trying to tell here. Okay. Let's zoom. Check the HCG levels. What is the HCG level? It's negative. She's not pregnant, you can say. So you exclude pregnancy. She's not ectopic. Okay, story over. Now come to this side. It is positive. That means she is pregnant. Now just check whether it is normal pregnancy or abnormal pregnancy. So here there is one outlet for normal pregnancy. It is in the uterus and everything is going fine. Okay, then fine, leave it. Now the uterine cavity is empty. But the beta HCG came positive. Now you're going to do laparoscopy. You're going to find this unruptured tubal ectopic pregnancy. They're saying, okay, it is not ruptured yet. Okay, fine. Now what will you do? Expectant management, whether it is regressing. Okay, fine. Then you leave it. Medical means what? You will do methotrexate, potassium chloride. Very good. Then otherwise you'll give systemic methotrexate if it is a huge one. Right. Okay. Then coming to unruptured, what surgery you want to plan in case medical is not going to help? Surgery you will do salpingostomy. Very good. Or you can express from the distal tube, milking and all that. Then salpingotomy, which they don't do nowadays, right? You can do segmental resection and anastomosis. Very good. So all this becomes the treatment for what? Unruptured. Very good. You are very smart. Unruptured. Now let us go. Third and last thing they have written here. It is ruptured. There is the patient has clinical features. There is shock, instability, hemodynamically there is instability. Okay. So you will resuscitate and do laparotomy together. Yes, you know this already. We will do laparotomy and resection. Resuscitation together. Then you will do salpingectomy. Very good. You are. One last term called as persistent ectopic pregnancy means this ectopic pregnancy continues. That means what? There is incomplete removal of trophoblast. Got it? Single dose of methotrexate is the solution to everything on earth. Ectopic means a methotrexate. Salpingostomy. That's it. 2 words. So in this video you have looked at what? Ectopic pregnancy. I hope you understood everything. Bye bye.